So good afternoon, everyone. Thank you for joining us for this program on understanding correctional health. My name is Matt Kostecki, and I'm the Community Outreach and Education Coordinator with NAMI Greater Cleveland. And today we are joined by two presenters who are from MetroHealth, and they will be explicating this topic for us. So just a few housekeeping notes before we begin. Please do remain muted throughout the presentation. Please utilize the chat feature if you have questions. We will also be dedicating at least 15 minutes at the end of this hour for general Q&A. So if you have questions to pose to our presenters, we will definitely have time for that. And I will be monitoring the chat throughout. This is being recorded and will be posted to the NAMI Greater Cleveland YouTube channel later this week. And I will also make sure that you receive the slides for today's presentation as well. So we will conclude with an evaluation, which I will ask you all to complete for us before we end at the very ending. So just briefly, I want to say a few words about NAMI Greater Cleveland, so you are aware of who we are. If this is your first time attending a webinar with us, NAMI stands for National Alliance on Mental Illness. It was founded in 1979 in Wisconsin by a group of mothers of children with mental illness. And they formed NAMI as a grassroots coalition around their kitchen tables because they wanted to create a movement that would support greater education, support, and acknowledgement for families affected by mental illness. And since then, NAMI has become a national organization, largest grassroots mental health organization of its kind, represented by state or local affiliates in all 50 states. And NAMI Greater Cleveland is the local affiliate that serves Cuyahoga County. Our mission is dedicated to improving quality of life for individuals with mental illness and their family. And we do that by providing support groups, educational programs. We have a helpline that people can call for assistance, referral to the correct resources regarding mental health or substance use, or other resources that are helpful for one's wellness and well-being. We are also engaged in the work of advocacy, reducing stigma around mental illness, educating diverse audiences about mental health, such as law enforcement, healthcare professionals, university students, middle schools and high schools, corporate groups. And really, we're in the business of helping individuals living with mental illness feel less alone. That's one of our core values. And obviously, we also do education like this, providing information about special topics related to mental health and community resources. So with that being said, that's my little spiel about NAMI. I'm going to hand it over to Dr. Bruner and Dr. Baskin to share their screen, introduce themselves, and get started with our presentation. So thank you for joining us.
Good afternoon, everyone. I'm Dr. Julia Bruner, Senior Vice President for Behavioral Health and Correctional Medicine. Thank you for the invitation to present our story in relation to correctional medicine and some very positive outcomes in relation to what we've been doing in the jail. And Dr. Baskin will be presenting the majority of this presentation because he's the medical director for the space. So with that, Joe, do you want to introduce yourself?
Absolutely. Thank you. My name is Joseph Baskin. I'm a psychiatrist and a medical director at the county jail.
Okay. All right, so I'm going to share my screen. All right, and this is not going to be the presentation style that you're going to see. Hang on just a second. Okay. All right. So this afternoon, we're going to talk about
Bruner,
correctional medicine.
we're not seeing the slides.
You're not seeing the slides. All right, hang on a second. We just practiced. Okay. Oh, maybe it's because I need to share my screen. Now, can you guys see it?
Yes.
Okay. All right. So we're on the first slide now?
Yes.
Okay. All right. So this afternoon, we're going to share with you what correctional medicine is and how we function in the Cuyahoga County Jail. Joe's going to review the mental health and addiction services that we provide at the Cuyahoga County Jail. And then last but not least, we're going to share how to communicate and how we provide connections to care as people exit the jail. So correctional medicine is a different type of clinical care. You know, what I like to envision or like to talk about in relation to the jail is imagine a small town, all living in two big buildings. So 1,600 people with a variety of different needs, a variety of different concerns and skills, and all needing support by a clinical team. It's a mix between from living on your own to being in a nursing home, and in some situations similar to being in the hospital. And we started a transition in relation to care back in 2019 within the jail. And that included the goal of receiving accreditation from the gold standard in relation to correctional health, the National Commission on Correctional Health Care, and remaining compliant with Ohio Administrative Code, which is a requirement in relation to jails. And we have achieved those goals. We've also worked to minimize the risk of inmate harm through ensuring that we have good, comprehensive care policies and procedures that our teams can execute on a consistent basis. We provide acute health care in the setting that we are capable of in the building. And we'll go into a little bit more details around this through the presentation. And we consistently work to meet the needs of those who have chronic disease who are housed in the jail. And that is something that is critical in relation to ensuring that people either become healthier or stay healthy while they're incarcerated. The other piece, which is really important to our team, is ensuring that when we're providing care, that we're doing it in a consistent way that is safe, that is respectful, and that's efficient, meaning, you know, that people are getting the services that they need in relation to their health. And then the last piece is, you know, so through this time period, there was also the pandemic, and the jail is obviously a congregate living space. We worked very diligently across the team and with jail administration and the officers to limit transmission of COVID in this space, and to consistently provide strong clinical care that successfully limited morbidity and mortality as it pertains to COVID over that 2-year time period.
I think it bears worth mentioning just how much you limited it.
So Joe is pushing me to share. So in many jails and prisons, unfortunately, there were many people that died during the pandemic, related to a variety of different reasons. As a team, we successfully prevented many deaths. We had one death related to COVID at the end of 2020. But that was a single individual out of approximately 25,000 admissions a year. So with that, you know, practicing medicine and providing clinical care in a jail, as I said earlier, is different than people walking into their clinic. When you walk into a clinic or you walk into an emergency department, typically you're there, you're asking to receive care from a nurse and from a provider. When people walk into a jail, that's not the case. It's often the very worst day of their life or one of the worst days of their lives. And engaging in someone in relation to talking about your health history, your substance use history, your mental health history can be very challenging. And so that process gets started very early on when people enter the jail. We do questioning as soon as people walk in before the jail will transfer custody over to the county. And we do that before people are housed in their housing units. And that's really critical for us to do because we need to know what medicines people are on, what their risks are before they get housed somewhere in the jail. The housing units are set up in either single rooms, double rooms, or dorms. And the length of stay, you know, is ranges in general. So in 2019, the average length of stay was 29 days, but the median was 3.8. So what that means is there are many people who come into the jail for a very short period of time, but there's about 15 to 20% of people who stay in the jail for a longer period of time. And so that's why there's a variance in relation to the average length of stay and the median length of stay. Another piece that we like to make sure that people know is we have a clinic in the jail. We don't have what's termed an infirmary, which is something that people see in movies and see often in prisons. Most jails don't have infirmary, which means hospital type care available. We provide largely outpatient level services with some caveats to that, but in general, it's intended to be an outpatient clinical practice. The team is there 24/7. So we have nurses, we have medical assistants, we have dental hygienists, we have LPNs, we have paramedics, we have RNs, all within this building. We have a pharmacy, a fully functioning pharmacy in this space, including a PharmD that really supports a great deal of the work in relation to immunizations and some of the mental health meds and some of our higher risk medications like Coumadin, blood thinners, those sorts of things. We have access to radiology. We have jail liaisons and patient navigators to support that transition into outpatient. We have quality specialists, we have infection control. We have, obviously we have a strong, very strong behavioral health program that you're going to hear more from Joe about. And then our providers have come from a diverse background. Many of them have worked in emergency departments. Some of them have been primary care doctors. We have women's health on site because we have women who are pregnant and require care as well. We have dentistry. We have people who provide care via telehealth from our main campus at Metro. So if a patient needs to see a neurologist, we can facilitate them seeing that neurologist without having to transport them over to the clinic itself. And then obviously one of the things that we're focusing in on today is our addiction and our mental health team and those specialists there. And when someone comes into the jail, they get that pre-screen assessment, which is a quick and dirty way for us to say, yes, this person doesn't need to go to the emergency department before they come into the jail. Sometimes people do. If someone recently hit their head on the way into jail and they have a trauma that wasn't evaluated, they need to go to the emergency department before they can come into the jail, because as you progress through this two large buildings, there's not the same level of access to care because you're now in a housing unit. And so we need to make sure that people are clinically stable before they enter the jail. We review all their medical conditions. We do a complete medication review. There's a mental health assessment that's done as people are entering the jail. We do substance use screening, and we use best practice tools in relation to looking for potential risks for withdrawal or detox requirements. Our nursing staff will initiate the orders in relation to medications. They'll provide clinical monitoring and set up appointments to see the medical or the mental health team as they're first entering that jail. And as you can see the numbers in relation to admissions, it's not a small number of people that walk into the jail on an annual basis. In 2021, it was 19,000. In 2019, it was 25,000. So, we provide care in a variety of different ways. Some of that is in the clinic itself, but a lot of that is done within the housing units with the medical staff, the nurses, the physicians, the advanced practice providers going out to the housing units to see the patients and assess what their clinical needs are and provide the best level of care. We also look at the population not just as an individual, we look at the population as a whole. And so when we can see that in general, that there are on one basis, so you can look on the slide, you can see that it says, wow, 1,100 people with mental health illness in a population of around, I think when I took this picture, it was a total of around 1,700 people. 1,100 people with mental health illness within a jail, and about 900 of them with severe persistent mental illness. What that tells you is that oftentimes, and I think we know this from the news media, jails are now the areas where there's a higher percentage of people that have mental health needs, and they're considered, the state hospital versions now, because the state hospitals were deconstructed in the 70s and the 80s. And so with that, I'm going to transfer over the presentation to Dr. Baskin, and he's going to share the advances that we've had in relation to mental health and addiction care within the Cuyahoga County Jail.
Thank you, Dr. Bruner. I want to just briefly discuss my background. Before coming to Metro, I worked for 9 years at the Cleveland Clinic here in Cleveland on a suicide unit. And so in 2018, 2019, there were issues that occurred that we'll discuss more in depth, but I saw this. I grew up in Cleveland. I'm also forensically trained. And so seeing what was going on, I'm very passionate about mental health treatment, especially in the jail. And there's a lot of us there who feel that way, who are there to try to help as best we can. Just to reiterate, 65% of inmates are, suffering from mental illness. Not all of them have severe mental illness that requires immediate treatment, but a significant portion, because jails are the de facto place where especially people who refuse treatment, and this is a big frustration for those who take care of family members, friends who have mental illness, is a lot of times they don't want treatment and they end up needing to have it forced upon them in some manner. And so in the jail, this is one of the last places, one of the last safety nets where they come to, and we see them as our patients. All right, we are not judgmental. We are not interested in the legal aspects. We are interested only in providing the care that we think is necessary at the time. Right now, we're averaging about 1,600. When I first started, it was far greater than that. Dr. Bruner, in collaborating with the judges, successfully reduced our population by about 50% before the pandemic, and that had a lot to do with our ability to handle the pandemic. Of course, one would think that with the fewer amount of inmates, it would be easier, but obviously COVID added a layer of stress that I don't need to reiterate over here. Okay, I'm sorry. Next, please. Right. So as I was saying before, and if you were following the news, in about 2018, 2019, there were some suicides, there was overdoses, there was a lot of issues. A code green is something that the security uses to describe a suicide attempt. It ranges from actual suicide attempts to people who are just essentially telling us that they're in distress. There were a total of 46 code greens in the second and third quarters of 19. 30.5% of individuals suffer mental health were not identified at intake and not referred to mental health. So as a major overview of what we did was a identifying of who is in need and of allocating resources. And that's a simple way of putting a very complex process of, as Dr. Bruner outlaid, when they come in, from the moment that they come in to the, while they're there, is identifying those people who need to have our services. I would distinguish between those who are struggling with what is a very difficult process, the incarceration process. One of the major issues of being incarcerated, especially in a jail, as opposed to a prison. In a prison, you've already been sentenced. You already know what you're looking at in terms of length of time. In a jail, it's what we call a provisional existence. You can be there for a day, you can be there for a year, you're not sure. And that unknowing leads to a lot of anxiety. It's a life in limbo, and it puts the stress level just at the edge of what a person can take at baseline. So people who come in a priori are going to have stress being in jail. And then there are those who suffer from major mental illness. And that's another area that we try to very much focus our attentions to. Some of the other issues were a formulary mismatch. We didn't have a lot of staff. The clinical records between our jail and North Coast were inconsistently maintained. So why that's important is because North Coast is our state hospital. And when people come into jail, let's say their lawyers or their judges want them assessed for competency to stand trial. In other words, are they too mentally ill to stand trial and do they need to have medications? They're sent to North Coast. In the jail, and this is an important point, we cannot forcibly medicate outside of emergencies. Meaning if somebody is calm and chooses not to take their medications, even if we know that they're mentally ill, even if their family knows they're mentally ill, even if the judge and the lawyers know, they cannot be compelled to take it. That is a Supreme Court case. We cannot compel them. North Coast, on the other hand, is a hospital, and there at North Coast, probate judges take over and they can forcibly medicate to restore competency. And then they come back to us. So not knowing that the data, what they found, what they didn't find, was causing us a lot of issues as well. This is a fishbone diagram. Rather than get into all the details of it, what it really is discussing is what were the issues that we saw when we first came in that we wanted to solve, right? Seeing people where they were, the training for the correction staff, the training for our staff, having information. Communication, I would say, is the single biggest, single most important factor for what we do. Communicating with the courts, communicating with North Coast, communicating with the community mental health centers, and communicating most importantly with security. That's on a one-to-one level, meaning the officers that work on our units, on our floors, communicating with them about what's going on. They, in a lot of ways, are our eyes and ears. They see what's happening with our patients on a moment-to-moment basis. Obviously, they're not clinically trained, but they have a good sense of what's happening, and we collaborate with them to understand. We collaborate with the senior leadership at the jail as well, in letting them know people that we're concerned about, people that we want specific things done for them. We also communicate with the courts to let them know when there's somebody who we think needs to go to the hospital, to North Coast, or somebody who needs to be assessed for their competency and things of that nature. So when it came to suicide, one of the big things that we did was identifying those people at risk. We came in July of 2019. They hired a behavioral health manager. Her name is Lindsay McMillian. She's a social worker who worked with in community mental health and Metro at the Adams Board. Very, very dedicated and experienced. And she started to develop programming right away. I came on board in August of 2019, and we started implementing some basic changes to the way things were set up. Simple thing was, when the person was suicidal, we took away their clothes so they couldn't hang themselves, and we gave them these smocks that they wear. They're not terribly comfortable, but they can't be used to hurt themselves. We created units, specialized units, where the people that we wanted to keep an eye on more closely they're close to where we are. We're on the 7th floor of the jail 1, and they're with us on the 7th floor. We also created step-down units, places where these, if they were not as acute, but we still wanted to keep an eye on them, we created those units. Everything got thrown into a little bit of a harum scarum with COVID, but we still maintained that certain organization. We made precaution statuses and made these placards that went on the door. And that was important for communication with the officers, identifying to the officers what was going on and why we were concerned. The security staff at the Cuyahoga County Jail runs in 4 shifts. They run Sunday, Monday, Tuesday, Thursday, Friday, Saturday, so 2 days of the week, and then 12 hours each of those, so 4 shifts. And I like to say that that's 4 shifts too many. Ideally, you would have somebody doing it for 168 hours constantly. Obviously, that's not possible. But one of the things that happens when you have 4 shifts is that communication can wane. And the jail population, aside from whatever else they are, they know this well. And the ones who want to can use that to manipulate by pitting one side of the week against the other, the nights against days, mental. So communication is key. Some of the other things that we did was involve training. When COVID came in, we created intake units. So we organized the jail according to COVID to isolate and to test. This way we kept the COVID numbers down and we kept the transmissions down. But it made it more difficult for us in terms of mental health because we had to have an additional unit for COVID intake who were also mental health. We did that. We had to stop groups that we had started, that we had really developed. And the groups are an important thing for acclimation to the jail in general. Those are a great way to provide care to a large group of people in addiction, in anger management, in so many different things, acclimation, trauma, so many different areas that we did. And that was really one area we suffered with COVID, that everybody across the country suffered, was the isolation and our inability to provide that kind of care. When COVID initially happened and started, we would provide daily rounds in the COVID pods for the people with COVID. At that time, as you remember, we didn't know what was going on, and it was a very scary time. And so we were really aggressive in our approach to that. That lessened as we started to become more understanding. And in 2022, this year, we were able to reintroduce groups, and that has been a big impact on our overall programming. We have nine providers, prescribers. We have countless social workers, really a full team arrayed to provide what we can, both for those with major mental illness and those who are just, trauma is a huge part of what we do, a huge part of what we see. And so somebody who's experienced trauma, the effect of being in jail lots of times exacerbates that trauma, and providing that level of support is something that is important to us. Another thing that we did with regards to creating a overall quality was we started to review safety event reports. These are instances where something happened that we want to improve upon. First of all, we want to see that, make sure that we're addressing whatever needs to be addressed, and then see how we can prevent that in the future. Quality reviews, taking the sample of patients and intake, try to see what we can do to improve on that. Doing reviews of the electronic medical record. The electronic medical record is the same one used at Metro, and it is very helpful. Right now, we are linked to several of the community mental health centers, as well as the Cleveland Clinic, so we can see a lot of a prior history, especially a mental health history, in order to know how to move forward with treatment. Plus, we track the number of code greens and daily security brief. Every day we meet, medical meets with the security leadership, and we discuss what's going on today, what's happened, and what we're doing for the day. Plus, we track the number of precautions. Precautions are seen on a daily basis. So if a person is suicidal, they're seen daily until taken off. And if they are psychotic, they're placed on precautions, or manic, and seen daily until they're taken off. Another thing that Lindsay implemented was having somebody follow up, a social worker follow up with somebody who was on precautions. We can't mind read. And an interesting difference within the community versus the jail is, in the community, generally, when somebody says they're suicidal in the community, they're generally not suicidal. It's the ones that don't speak that worry us the most. But in jail, there's a population of people who will announce their suicidality and who will up the ante, so to speak, until they get their needs met, their perceived needs met. And so we have to be very mindful of that. We're looking for those who are quiet, and we're looking for those who are loud. And it's a complex thing, but we do a lot of assessments, and we do a lot of communication amongst ourselves to discuss who we think is at risk. We talk to security about who we think is at risk, and we implement plans to reduce that risk as best we can. And every time we have a code green, we discuss whether it was a real code green, meaning a suicide attempt, versus somebody who's just injuring themselves because they're upset, because they want to show their level of upset, or other suicide events that are really manipulations to let us know that there's something else going on, that they're upset about something else. So like I said, we talk every day. We talk with security. The way that the jail is set up, the corporals are the initial leadership level over corrections officers. They are our direct liaisons, because we talk to them constantly about how we can better improve the care, how we can identify those who are in real need, and how we can focus our energies to help. We talk with the mental health court. We have 5 judges in the Cuyahoga County Common Pleas Court who represent the mental health docket. They see people with major mental illnesses. They have a court liaison who is a very hardworking woman by the name of Lottie Gray, and we liaise with her on a daily basis to let her know either when somebody has returned to jail, and she'll do the same, who we know, versus somebody who we're worried about and we think hasn't been properly addressed as somebody having mental illness. We are in daily communication with community mental health organizations. We have liaisons from the community mental health centers embedded in our jail. And that helps us inordinately because we can reach out to them, formulate aftercare plans, discuss medications, discuss what's needed. How can we help minimize the chance of them returning to jail? And then the state hospitals, as I said earlier, we communicate with North Coast. Twin Valley down in Columbus is the maximum security forensic hospital in Ohio. And we send to both of those institutions, and we hear back from them about what's going on with the patients who we sent down, whether they're coming back, and what was their determinations in terms of their competency and their mental illness. It's very helpful for me because in the jail, it's not a normal environment. That much is clear. But there's also secondary issues going on, meaning somebody might have an interest in being declared mentally ill when they're not, or vice versa. And so having them go to a hospital where they're observed in a more hospital setting helps me, especially when I'm having a difficult time differentiating what might be major mental illness, what might be trauma, what might be a personality disorder. And so I find those collaborations very, very helpful. These next few slides are going to be basically visual ways for you to see what happened since we've been here, what happened. So precautions went down. In other words, putting people on precautions has gone down. I think the next slide is a much more. So here's our code greens. So you can see just by looking at the slides, just our graphs, code greens have gone down. Suicide attempts have gone way down. A lot of it has to do with basic identification and treatment. We still have situations that arise, but we haven't, thank God, had a suicide at the jail in the 3 years that we've been there. Here's another just visual way of seeing, here's some of the things we've done. 5,600 social work visits, 1,700 psychology visits, 7,500 psychiatry visits, 25% decrease in code greens from 20 to 21, 73% decrease in suicide attempts from 20 to 21. There are still people in distress, but we are addressing them, and we are working, especially with the addiction population. That's and that's something that, we could do a whole webinar just on that. They come into jail. A lot of times they don't necessarily want to announce that they're using drugs. So some of them are obvious that we can identify, but others we don't see because withdrawal tends to occur after you've been in jail, right? A lot of times people come in they're intoxicated. So with opioids, 1 to 2 days later, they start to show symptoms. With alcohol, it can be 3 to 10 days later. We see a lot of unusual things in jail. What in the community would be zebras, what in medicine we call zebras, in the jail are not. We see a lot of unusual things. We've had, in my time, I've seen at least 3 people suffer from delirium tremens, which is a very severe alcohol withdrawal syndrome, 10 days later. So we treated them appropriately. They were fine. And then all of a sudden, 10 days later, they started to show symptoms. That's very late withdrawal. And it's just represents some of the challenges that we see. Identifying the people in need, especially with addiction, has made a big impact on the suicide stuff as well. We have obviously expanded greatly the access to care for addiction and behavioral health. We see a lot of behavioral health more than addiction. A lot of it has to do with that when somebody comes into jail, even if they don't suffer from major mental illness, they're still under a tremendous amount of stress, and we are addressing that. All right, so, we're always doing quality improvements. We're always looking at what are we doing right? What are we doing wrong? How can we improve it? Thankfully, the jail presents a lot of challenges that we are constantly addressing. Some of the challenges that we address come back and we have to keep at them, and they come back in different forms. And we're just always looking for ways to improve our care. So 0 completed suicides over a 3-year period is what I said. There are people that we worry about, and the people that we address more aggressively. There are people that unfortunately we don't see necessarily. And the jail is like Dr. Bruner said, once you get out into jail 2, into some of the housing units, it's much harder for us to know what's going on. And we have we have what's called a signal to noise ratio problem, meaning we have a lot of people who are clamoring that there are problems. And oftentimes the ones who clamor the loudest are not the ones that necessarily are in the most need. And so we have to really be listening for those signals, those ones who are really in need, lest we lose them in the greater noise of the people clamoring.
Yeah. So one of the things I'd like to add, just as a comparison, in jails and prisons across the nation, for every 1,000 people that are currently in a jail, there's, this is a sad statistic, but true, that there's at least one person that dies of a suicide while they're in jail annually. Over the last 3 years, with the programs that Dr. Baskin and Lindsay McMillian developed, and as a team, we worked with them to just continually try and improve. They've done a phenomenal job in relation to reducing suicidality in the jail, reducing and increasing the supports, and also improving just general psychological health within the space. And that is not an easy accomplishment. And they've worked diligently, not only on the individuals, the needles in the haystack that he's talking about, but also for the broader group in general, because being in jail is not the environment that any of us want to be in. And it can be very challenging and traumatic as an experience. So I think the other piece that we suspect that you may be interested in is how as a family member would you communicate with our team in relation to the care of your family member that may be in jail or your friend. And we follow the same process that we would use in our outpatient space and in our hospital, which is we have you call our patient experience office. And so that number is provided here in this slide. It's 778-5800. Please understand that the rules in relation to sharing patient information and connecting are the same for us, whether they are an incarcerated patient or they are a patient that I'm seeing in my clinical practice on a regular basis. We have to have their permission. That's a requirement. So our team always will ensure that they get permission before they actually respond back to you in relation to your concerns.
Although, if I can just add something,
Sure,
you can
absolutely.
always relay concerns. You can always relate concerns, and those concerns are very helpful for us because information is very, very helpful. We just might not be able to tell you what's going on, but you can always tell us what we should know in order to take care of your loved one.
Yeah, that's a very good point. Thank you for that. The other piece we want to share with you is our communication and connections with outside community-based mental health agencies or with their hospitals or their clinics that they go to in general. We have a jail liaison program that's funded by the Adams Board that Lottie Gray, many people in this group may know Lottie just because of her dedication to this group. And she will work with all of these agencies to ensure that your family member or you have good access to ensuring that people are getting services once they leave the jail. We have an exam team, which is part of our addiction medicine group, who also ensures initiating treatment for opioid use disorder on site, and then facilitating and continuing care as they exit the jail. And then I think you've heard during this presentation that we do have a good process in place in relation to the mental health court docket to ensure that when people are being released, that we know in advance so that we can ensure that their medications are sent to their pharmacy so they're not going without medicines as well. So with that, I'm going to pull down. I'm going to stop sharing my screen. And Matt, if you want to either relay the questions or I think we're ready and open for questions at this point.
Yes, so we have started to receive some questions. and I will just read those out. So I received one question from Danielle, which is, why are certain medications not allowed in the jails? For example, injectable antipsychotics. Are there any efforts to find ways to ensure continuity of medications for those prescribed meds that are not provided in the jails?
So as a general thing, we do have injectable medications. We just don't have every injectable medication. And the way that we work it is, and there's a couple of questions there. Let me answer the injectable question first, which is we will reach out to the community mental health center. So let's say Frontline is administering Invega. We don't have Invega, but Frontline will deliver Invega to us and we will administer it. But I do have, we have Haldol, we have Prolixin, we just don't have some of the newer ones, but we will work with the community mental health centers for them to bring it. As to why some others aren't, so we have formulary restrictions similar to the other corrections facilities in Ohio, and we can't use certain things like certain controlled substances. Big one is stimulants, so Adderalls, Concertos, Ritalins. We're not able to use those, benzodiazepines, Xanax, Valium, because of diversion and issues with security in the jail. But we go to great lengths to provide alternatives that we can to treat whatever, to treat conditions appropriately.
Okay, a few more questions. Are you able to share contact information for the members of your team or program that collaborate with community case managers?
So I think this question is really who is our connection to care in relation to case management, and for that group, that's Lottie Gray, who runs the reentry program. The other avenue that we can share is contacting either Dr. Baskin or myself via email, and we'll facilitate that group gets connected with our management team on site.
Okay, maybe we can put Lottie's email address in the chat.
Yeah. Yep.
Are you able to work with, referring to connections to care, are you able to work with managed care teams, for example, Buckeye?
Yeah, so when an individual is incarcerated, their healthcare is paid for by the county. So Medicaid is not paying for any of the services while they're in the jail. We do communicate with CareSource and Buckeye around their case management teams when they reach out, and that from a state level, Laurel Domansky Diaz and I are working within a committee with the Medicaid managed care organizations to help improve people signing up for Medicaid as they're exiting the jail, and also ensuring that there's a good connection to care as people exit. I think one of the challenges that we face as a clinical team is we don't always know when people are leaving the jail, right? And usually the person who's leaving the jail often doesn't know when they're leaving the jail. And when they leave, the concept of saying, oh, wait, hold on, I want to make an appointment to see my doctor, I need to get my medicines, versus I get to leave the jail as a priority, has a tendency of people decide, I will deal with that after I get out of the jail, I want to go home, right? I'm ready to go home. And so that creates a little bit of a challenge for us in relation to those connections to care. But some of the things that are available in relation to working with Medicaid managed care organizations, I think will help us with that, ensuring that people have that access. Okay, Joe, looks like a bunch of these are yours.
Yeah, looks like we have several that are addressing withdrawal protocols around benzodiazepines and other medications. Can you speak to that?
I can. If they're identified as being on benzodiazepines from like a community provider, which we can identify, we do have protocols to place them on. Or if we suspect that they're using them illicitly, we also put them on that same protocol. So we do put them on withdrawal protocols for benzodiazepines. Yeah.
I
We
received one.
we don't just
I
stop
think
and
that-
cold turkey.
Yeah, before we go on, I think the intention that we have clinically at the jail is to ensure that people are receiving treatment to limit their symptoms from withdrawal and reduce their clinical risk. That's something that the team is very aggressive around because we know the risks in relation to withdrawing from medications. Do you want to say anything more, Joe?
What's that? I'm sorry?
Do you want to say anything more about that?
No.
I received a question. How can an outpatient
I don't know
psychiatrist?
if my screen is frozen or,
No, we can see you. Can you hear us?
okay.
How,
Yes. Whether you're-
how can an outpatient psychiatrist reach one of your staff with info on our patients when they are admitted to you?
That's a good question. There are outpatient psychiatrists where, though? If they're through the mental health, community mental health, look, if they're community mental health, some of them we have access to their notes. If they're not through community mental health, in private practice, that's unusual. How can they get? I suppose through the patient experience would be
And
one way.
They can also call jail administration, and jail administration will connect the outside provider with our team. So they can call the jail, and we can facilitate those conversations.
Do you ensure your patients are covered by Medicaid or some insurance that will pay for their prescriptions when they are released?
So we try and facilitate people getting placed on Medicaid when we can in relation to supporting that medication or setting that up with an appointment as they're exiting the jail. When those scenarios occur, we want to facilitate getting them in so that they can get those medications. So usually that first step is seeing a provider and getting those needs met and evaluated so that they can get their medications for free or at a reduced cost.
Oh, we lost Dr. Baskin.
Nope, he's still there.
Is
Yeah,
he?
I'm back. I know somehow I got kicked off.
Oh, you're back. Okay. Looks like
Hopefully you get kicked up again. There he is.
there he is. I put the spotlight back on him so everybody can see him. Okay. Other questions? Let me see. A question from someone here about clinical evaluations when they occur. Are they occur like, if you can speak more about that? This person is asking about their son being evaluated in the jails when he was not manic, not dealing with an episode. What's the kind of protocol around? Is there a reassessment done when a person's symptoms change? Can you answer or speak to that at all?
I sure can. So the nature of psychiatry, and it's not an easy nature to deal with, is that it's episodic. And so I can see somebody who looks perfectly normal, who might have, manic episodes or vice versa. So whenever I see somebody, regardless of when I see them, I'm doing a thorough chart review, to determine. And if they tell me that there's a history of mania, we discuss whether they should be on medications, and I follow them up. Just like I would in an outpatient. So if I feel this treatment that's necessary, I will start them on treatment. If they feel like they want to be on treatment, let's say they were on Depakote previously and they want to be on that, we do that. But it's a collaboration with them, and I always follow up with people. Now, if they are in a manic state, they will be identified quickly and they will be placed on precautions, and then we see them right away. And every time I see somebody, especially if they're manic, then I follow them as I would in either in an outpatient or even in a hospital, where I'll see them the next day, then I'll see them 3 days later, then I'll see them a week later. But I will always follow up with somebody as long as they're in jail to determine what's going on, determine the best course of action.
Thank you. So we still have a few more minutes for questions. In the event that anyone would like to put their question in the chat. I did also drop the link for the survey, the evaluation for this presentation. It's brief, it's anonymous. Please complete that survey before we finish today. It's really helpful for us to hear your honest feedback about the usefulness of these programs. And I see I got out, there's another question here. Is there opportunity to seek out one-to-one, I guess that means individual counseling sessions for behavioral health while incarcerated?
There are. So the long and short of it is they get a referral, and then they will be assessed, and then either the psychologist or social worker will determine how many. Usually it's brief, usually it's, let's say, 4 to 6, trauma related or something like that. But that'll be, the therapist decides. But yes, there is one-to-one in the jail. But there's also groups, and there's 2 jails. And so in jail 2, which is more misdemeanors and lighter offenses, there they focus on groups as opposed to one-to-one, where in jail 1, it's more one-to-one.
Thank you. A lot of good questions. And
Well,
I
I'd
will,
like to take the opportunity to say thank you to NAMI for inviting Joe and I to this webinar. I think the more we can normalize the conversation around incarceration and allow families to engage and see that this is something, this is a scenario, this is a setting that requires care and attention, the better. So I appreciate the fact that you reached out and asked for us to come and talk about how we provide care within the jail. So thank you.
absolutely. And as a reminder to everyone, I will ensure that these slides are provided to you afterwards. I'll probably send that shortly, later this afternoon at the latest. I did drop the evaluation link again. Please open that up and complete that. Thank you to Dr. Bruner and Dr. Baskin to generously donating their time and expertise to educate the NAMI community on this topic. Clearly, since we have so many folks with us today, it was much needed education on this issue. So thank you all for being here as well and for asking so many good questions. Hope everyone has a great day and stays warm. Bye.
Thank you.